Hello and welcome to WVU Medicine Tuesday Talks. I'm your host, Mary Ravazio Menard. Maybe you've heard of Inspire, an obstructive sleep apnea treatment that doesn't require a CPAP mask, but instead uses a remote-controlled implant device to regulate breathing. But Inspire doesn't work if you have a different kind of sleep apnea called Central Sleep Apnea, or CSA. Now a new treatment called Remede is available for CSA patients. It's a CSA pacemaker that regulates breathing while you sleep without a CPAP mask. So today we're talking about pacemakers for central sleep apnea and sleep apnea with Dr. Sunil Sharma, Chief of WVU Medicine Pulmonary, Critical Care, and Sleep Medicine. Welcome, Dr. Sharma, to Tuesday Talks.
Thank you, Mary. Thank you for having me here.
It's great to have you here. So we were talking about obstructive sleep apnea, central sleep apnea there in the introduction. Let's start with what exactly is central sleep apnea?
Thank you, Mary. That's a great question. Most of us have heard about obstructive sleep apnea, where your throat collapses while you're sleeping. And in the right way, this is one of the most commonest sleep apnea. But there's another type of sleep apnea where people tend to forget to breathe. So it's generated from your brain, where the thermostat, which controls our breathing, does not create the breath itself. So that's called central sleep apnea, and it is very different than obstructive sleep apnea. It is much rarer, but it is definitely very fatal, and it is connected with certain disorders. So people need to be cognizant of the fact that those who have heart failure, those patients who have atrial fibrillation, abnormal type of arrhythmias, or stroke, are at a much higher propensity to having the central events than obstructive events. So that's the difference between obstructive and central. And unfortunately, the approach, the diagnosis, and the treatment varies between these two types of apneas.
So it sounds, is central sleep apnea more dangerous, for lack of a better word, or at higher risk for more serious complications?
In a way, you're right, Mary. It is a very fatal type of a disorder. We just don't know whether this is a marker of the severity of the heart failure itself, or it is dangerous in itself. What we know is that patients who have central sleep apnea and heart failure die much earlier than patients who have heart failure without central sleep apnea. So it does contribute to the fatality, and we have data to support that. However, it is obviously not as common as obstructive sleep apnea, so most people don't know about it.
Okay, so I was going to ask you who's most at risk, but it sounds like it's people who have had
heart failure, congestive heart failure. People are highly prone for that. In fact, heart failure patients are prone to sleep disorder breathing, whether it's obstructive or central. Half of them may have obstructive, and half of them may even have central sleep apnea.
Oh, wow.
What we know is that the more severe the heart failure, the more chances that you have central sleep apnea than obstructive sleep apnea.
Okay, but you said it's rare. I mean, are there any statistics on how many people have central sleep apnea?
That is correct. So as you are aware that the heart failure itself is of two types. One is systolic, one is diastolic, which basically means is your ejection fraction good, which is more than 45%, or it is low, which is less than 45%.
Which is how much blood?
How much heart is able to pump blood outside the heart.
Yeah.
So if you take people who have very good ejection fraction and heart failure, which is called the diastolic heart failure, you have about 15 to 20% prevalence in those patients. While patients who have systolic heart failure, where they are not pumping blood appropriately, have a much higher prevalence, about 30% of those patients.
Okay.
Similarly, in patients with stroke, you have a prevalence of about 10% of them having central sleep apnea. the numbers touted in atrial fibrillation, which is a normal kind of rhythm, is about 15 to 20%. So it's not overwhelming number of patients. Not everybody with these conditions will have central sleep apnea, but a small proportion of them will have this fatal condition.
Okay. So what are the symptoms of central sleep apnea? I mean, is it different from obstructive sleep apnea symptoms?
Quite different, Mary. So that is one of the conundrums of sleep medicine, is it's very difficult to diagnose central sleep apnea.
Oh.
And one of the reasons is that the common symptoms which are associated with sleep apnea, I snore, I think I quit breathing at night, I choke in my sleep, I wake up tremendously tired, or their partners being able to observe.
Yes.
And you may have heard some people say, oh, my partner snores like a freight train. So these are things which get their attention.
Right.
And then they get their attention, we come to know about it. Those are not present in central sleep apnea.
Oh, okay.
So think about it when you're not generating a breath in your brain. That patient can't snore. So there's no snoring because there's no breath.
Because you're not breathing. You're not breathing.
Exactly.
Wow.
So we sometimes call it the silent apnea.
Oh,
because
wow.
the patients are very silent throughout the night. Some of the very observant spouses can notice that he's quitting breathing, and there are periods where it doesn't appear that the chest is moving, but those are hard for them to do.
Yeah.
So what we rely is on patients who have the right kind of background. For example, you have heart failure. What we have noticed in studies after studies is the sense of profound fatigue that they experience.
Oh, okay.
Now, this is very non-specific.
I know.
Right?
Because fatigue is a symptom for so many things.
So many things, and
yeah.
heart failure itself can cause a lot of fatigue. But after all the adequate treatment, control of your heart failure, if the patient continues to have life-altering fatigue, profound fatigue throughout the day, sleep disruption, many of these heart failure patients may experience that they sleep for 2 hours, then wake up spontaneously, then sleep for a few hours, then wake up. So there's no consolidation of sleep like normal and non-heart failure patients may have. So these are signs, and as non-specific they are, these are what we are sensitized to pick up. And that's the education part of central sleep apnea and why it's missed.
So can it be picked up in a sleep medicine test?
Absolutely.
Okay,
So
okay. It's just getting you there. You're not going to see those symptoms necessarily to get you to take a sleep medicine test.
And that may be one of the reasons why the diagnosis is delayed.
Yeah.
Because it doesn't come to our attention soon enough. But if it does come to our attention, we have a gold standard polysomnography or sleep study where we use 16-channel patients sleep in a sleep lab, and we are able to spot whether the patient is quitting breathing because his throat is collapsing, or is it not breathing because the brain isn't generating a breath. So that differentiation can be done easily during the sleep testing.
So what are some of the current treatment options for central sleep apnea?
That is correct. So the treatment options for central sleep apnea, unfortunately, are limited.
Okay.
Before the advent of more advanced treatment, we did have something called adaptive servoventilation, which is a kind of an advanced CPAP machine, which allowed them to breathe when they were not breathing. And for the longest period of time, we used them with some success. However, there was a big trial in Europe in 2016, which suggested that some patients actually may do worse with that.
Really?
Especially the patients who had ejection fraction less than 45. These are the ones which say the heart isn't pumping the blood well. So there was a black box warning on that device, and we stopped using ASV, especially for those patients who have low ejection fraction. Fortunately, trials were going on as to how else can we fix this, and in 2017, FDA approved this new therapy which you mentioned is Remede, what we call is the phrenic nerve stimulation therapy. And basically, you might think of it as the pacemaker for breathing.
Okay.
So you have pacemaker for the heart,
Pacemaker
but
for
the
the heart.
first time it's a pacemaker for the breathing, because this actually generates the breath. So remember that when we generate a breath from our brain, it travels through the nerves, and through the nerves it stimulates the diaphragm.
Okay.
The diaphragm is the most powerful muscle for our breathing.
Right.
That helps us breathe. Now, if your brain isn't generating that breath, can we stimulate that nerve and create that breath by having the diaphragm contract? And that's the basis of this treatment.
So that's basic. So it's an implant, right?
It's an implant which goes just like any other cardiac implants or ICD or
Okay.
pacemaker, sits right below the chest, and it has a lead, a sensor lead, which senses whether you're breathing or not, and a treatment lead, which throws electricity and stimulates that muscle to say, hey, breathe, because you're not getting a signal from your brain, and I'm going to initiate that breath for you.
So does it just regulate your breathing throughout the night, or does it only give you the little shock? Is that an appropriate word? Is it a shock?
It's electrical stimulation.
Electrical
You're absolutely correct on that.
Does that just give it that to you when you're not breathing, when you're not getting the message from your brain to, hey, breathe?
Yeah, it could be simply defined as that, but it's a little bit more complex, that you have to define a period of sleep where it is activated. You can imagine that while you're walking or laying down, you don't want that electrical stimulation.
No.
Because one of the issues is that our breathings are highly regulated, and the fact that if you get stimulated in the wrong phase of your breathing, it can be very disconcerting for the patient.
Oh, yeah.
Let's just say a patient is trying to breathe out, and he hasn't completed that process, and the electrical current comes in and stimulates and asks him to breathe in.
Oh,
Your body can get confused.
Right.
That while I'm breathing out, and it's almost asking me to breathe in. And that could be a little bit disconcerting. So what we do is we have ways to have rail guards, preventative without happening that. And one of those is we define what is the period where he sleeps best.
Okay.
So the treatment gets initiated and terminated only during that period of time. So it's not operational outside that window. So one.
Okay.
Then we have other safeguards. For example, the patient gets up and he wants to go to the bathroom, or he's sitting up and watching TV.
Yeah.
So we have pitch detectors, which means if he is beyond a certain pitch and standing up, it gets terminated.
Oh.
So there are
this
many
is very sensitive.
Very sensitive and highly technical. And then even the electrical current. How much stimulation does a person require? Maybe somebody is more sensitive to the electric current. Others may not be. So this is a process of slowly going up on the current till the patient feels that this is the most appropriate level of stimulation for him.
Can you feel the current?
Yes, when we test him, we have the patients can tell us that they can feel something in there.
While they're will you feel it while you're sleeping? Like, will it wake you up?
Only if the stimulation is way beyond than what had been set up. What we do is we calibrate from the lowest electric, and we very slowly then calibrate it higher to the point where the breathing is appropriate, at the same time patient is comfort. So it's an art and a science. So we are constantly in touch with the patient, and it's actually, some of it is auto-regulated. So the machine is designed so that it's very slowly increase the current on a weekly basis, and it never crosses a certain threshold. And these patients are seeing us at every couple of months period of time, and we are calibrating because we can, look at the data, which this pacemaker is recording, and based on that we can further fine-tune the device.
Now, I know with Inspire you have a remote and you turn it on, but I think I read this turns itself on, right? You just fall asleep and it...
That is correct. As I said, that there are certain, safety guards, and one of them is that it is designed to get triggered only in a certain time period of your sleep. So yes, it is good. It's not something that you can control. It is something which is designed to fit your profile of sleep, how you're sleeping, and not something that the patient can control.
Okay, okay. So who would be a good candidate for this?
So certainly, patients with heart failure who, despite having good control of their heart failure symptoms, are continuing to having significant, profound fatigue during the daytime to the point it's debilitating to them. People with heart failure who have significant disruption in their sleep. If your whole night is disruptive, your quality of life the next day is going to be poor. And these people struggle with that on a daily basis. So this is one of the most important profile of patients that we look for helping out because our experience, and including the data which was published on the basis of which the FDA approved it, there was significant improvement in the quality of life. There was consolidation of sleep. They were sleeping better and they were feeling better the next day, everything else being the same.
Okay.
And of course, patients who had strokes and then end up having this type of breathing, and they are witnessing again sleep disruption, daytime tiredness, unable to participate in their usual daily activities.
Can you have central sleep apnea even if you don't have, heart failure or have had a stroke? I mean, can you have that without having a heart condition?
That is correct, Mary. There are conditions that can do that. One of the common one we see is use of opioids and morphine. And they can affect that brain center which produces the breath.
Okay.
And they can cause a central sleep apnea.
Okay.
And there are other conditions, some neuromuscular genetic conditions where you can see that. Sometimes you can see quitting of breathing when you go to high altitude, usually over 2,500 meters.
Okay.
So there are very conditions. We usually use clinical judgment to see whether they require treatment on that. And our focus generally is, and the data which supports, is mostly in heart failure patients and stroke patients.
So what are the benefits and the risks of the Remede system?
So, of course, as I said, the benefits is that if you have profound weakness or fatigue throughout the day, your sleep is disruptive, there's significant improvement in quality of life. We also have shown in that particular study that the number of central sleep apnea dramatically reduces after the treatment, and some post-hoc and post-marketing studies have shown that it continues to stay the same 3 to 4 years even after the implant.
Wow.
So your breathing definitely gets better, as we know. Your quality of life significantly gets better. Now, in that particular study, which was a randomized controlled trial, they looked at controls also, and they didn't find any significant adverse effects which were different than controls. But like any other procedure, it's a procedure. So you have any pacemaker type, your adverse effects, for example, bleeding can happen. Patients who have infection, that infection can spread. So that's why we want to make sure an expert sees them, make sure they don't have any underlying infection, they are otherwise stable for a surgical procedure, they don't have any bleeding risks. So those kind of assessment has to be made and is made, and these patients go through a consultative process, not just with a sleep physician and an expert, but also electrophysiologist or cardiologist. So we combine our expertise to see who's the right patient who's going to benefit from this therapy.
So is WVU Medicine the only organization in the state that is offering this treatment? That
is correct. This is WVU Medicine here at Ruby is the first one to start the Remede program. Again, it's example of a collaboration between the sleep experts and the cardiologists. You need special training in placing these devices, and we work closely to ensure that we have the right patient selection, and we have been very fortunate to have done several of these procedures, and almost all of these patients have benefited from that procedure.
Yeah, can you talk a little bit about the experience of the team at the WVU Sleep Center?
Yes, so we are very excited about this new modality because this was a segment of patients which we really didn't know what to do. And there was no proven therapy to help these patients. So one of the things was that it is such a rare diagnosis in such a way that many of the patients, technicians, may not be able to recognize it at night because they see obstructive so much that once in a while when they see central sleep apnea, they're not sure, should you count that as obstructive or central? So there's a lot of education and they understand now the differences and how to pick up that. So that's been a positive. There's much more recognition in our sleep community on not just saying you have central sleep apnea, there's not much we can do, but sharing that information with our patients saying, hey, there's a new procedure, you may benefit from that.
Okay.
So I think that education has certainly had a positive impact on the sleep community. And of course that has led to a very close collaboration with our heart doctors. Our electrophysiologists who are the specialized cardiologists who deal with the pacemaker devices, they have to go for a special training to get this device implanted, and they're working closely with us.
Okay.
So I think all in all, there's a lot of enthusiasm, and we hope to benefit a lot of patients in there because, as you know, heart failure is very common in West Virginia.
Yes, it is.
So just because of the amount of prevalence of heart failure, we know there's a lot of these central sleep disorders which have not been detected, not been treated. So there's a lot of work ahead of us, but we are very excited about it.
That's great. So I always like to ask before we go here, before we wrap up, what's the most important thing you want our viewers to know about central sleep apnea?
I think to the community, I would say that if you or your loved one has heart failure or stroke and you're witnessing profound fatigue, disruption in sleep, they're not able to participate in family events, then bring it to your primary care's physician's notice. I think there's increased education about it, and your primary care physician would be able to refer you or your loved one to the right experts, which is the Sleep Disorder Center at West Virginia University, and we can take it from there. The message to the primary care physician is that sometimes the patient will know how to address these issues. So maybe proactively asking your heart failure and stroke patients, how do you feel? When you wake up, do you feel energetic? Do you feel feel like engaging with the world, or you just feel like withdrawing? And despite being all of those good medications, if you're still feeling, maybe you have central sleep apnea which has not been detected. So I think with this dual education, we'll be able to spot and hopefully treat many of these patients.
Okay. Well, thank you so much for sharing all this information with us today.
Thank you, Mary.
It's exciting for something, we can create awareness for.
Absolutely.
Thank you so much. Well, that brings us to the end of this edition of Tuesday Talks. If you're looking for more information on sleep medicine issues, you can always visit wvumedicine.org/sleep. I'm Mary Ravazio Menard, and on behalf of Dr. Sharma and everyone at WVU Medicine, thank you for joining us.